Hello, and welcome to part 2 of the lecture on chapter 7 on neoplasias. So in the first half, we went over cell cycle and the things that can go wrong that cause the cell to start cycling out of control and making lots and lots of copies. And we stressed a lot about mutations and how the genes that control the cell cycle get mutated, and multiple mutations can lead to the development of these out of control cells. That makes us think, of course, that you can inherit that. And it turns out that most cancers are not due to an inherited mutation. Most cancers are due to mutations, what they're referred to as sporadic mutations, mutations that occur in the lifetime of that individual in their somatic cells. And so a very small percentage of cancers can be related to genetic inheritance. Now, let's talk about the ones that can. Those that are due to an inherited problem, it's usually a tumor suppressor gene, something that either helps with checking typos or slows the cell cycle in some way. It's one of those that is mutated. And then the way I think about it is this gives somebody a head start on developing a cancer. It's no guarantee that they're going to develop a cancer. It just makes it easier to develop a cancer. So they talk a lot about the second hit, having to get another mutation in that same gene on the other chromosome. So you get one chromosome from mom and one chromosome from dad. And so there's the same kind of information on both of those chromosomes. And if one of them is mutated, the other one can kind of fill in because you have the working copy of that gene. But if that one gets mutated, then okay, you're out of luck because that cell no longer can make that protein properly. One of the things that we see a lot in cancer cells is they arise because mutations occur. Sometimes the mutations occurring is an indication that there's something wrong with the DNA typo fixing mechanisms. Well, if that's the case, then these cells are the ones that are going to accumulate a bunch of mutations. And so as treatment for cancer continues with a particular patient, you may see the evolution of this cancer. There may be more mutations that arise, and you kind of have to go after the cancer cells in slightly different ways. So that's why tumor cell genes are tracked in the course of treatment, because if there's a new mutation that we know how to treat, there may be a new medication added. Okay. Here's a long list of different kinds of cancers. They're all fair game for the patho blog. This is in the PowerPoint, so I'm not going to spend a lot of time with this on the screen, or you can pause your screen and take a screenshot. But these are all things that are gone over a little bit in our textbook, and you can find plenty of research about them. The cell cycle, I went through it in great detail, so I'm not going to do it again. This material is covered on pages 216 and 217. I didn't go into a lot of detail about mitosis, and I'm not going to go into a lot of detail here. This note is to myself. I had originally written note to self and then realized you're going to think it's to you. So it's a note to myself to point out cells that are actively dividing obviously have to go through mitosis, right? And so the first chemotherapy agents attacked cells that were actively dividing, but it would attack all cells that were actively dividing. And so one of the things that's easy to see is you see these spindle fibers. They have to grow out and connect with the chromosomes, and they line the chromosomes up, and then eventually they pull the chromosomes to opposite sides of the nucleus, or opposite sides of the cell, and before the new nuclei can form. That was an excellent target for cancer treatments. The downside is that it attacks every single cell in the body that's actively dividing. And so that's where so many of the side effects of chemotherapy come from. And so what we're talking about, I think I mentioned in passing in part one, the thing about losing hair, because the cells that give rise to hair are actively dividing. But the cells of the skin, like, okay, so we're done growing. So our bone cells are not actively dividing as adults. But you're always sloughing off skin cells. They're actively dividing. Those cells are going to be affected by chemo. Production of any kind of blood cell is also going to be affected. Remember hematopoiesis, you're making red blood cells and white blood cells. That's going to be impacted by the traditional chemotherapeutic agents, which is why people are immunosuppressed, more likely to develop infections. I'm trying to think of other examples. Those are the ones that come to my the cells lining the digestive system. There's a significant nausea for a lot of patients. So you get the idea. These very general kinds of treatments that go after all actively dividing cells have general side effects that affect most patients or many patients. And that's why the big advantage of having targeted therapies. All right, so they're controlling the cell cycle. I had introduced certain terminology to you, the oncogenes and the proto-oncogenes and the tumor suppressor genes, but here are some more terms that you're going to need to know. There's a family of proteins called cyclins. You can think of those as the go signal. This is when the amount of this protein increases, that triggers the cell to start moving through the cell cycle. The molecules that are going to respond to that go signal have been in place. They're kinases. They're enzymes that are going to do a job. They phosphorylate something else. And they depend on the cyclin signal coming in and telling them to do their job. So they're referred to as cyclin-dependent kinases. These molecules basically slow down, they're tumor suppressor genes. They slow down the cell cycle until cyclin says go. So when the cyclin level goes up, these cyclin-dependent kinases say, okay, let's move forward. And then there's an inhibitor on those. So cyclin-dependent kinase inhibitors, they say stop no matter what cyclin is saying. So even if the cyclin level is high, these molecules inhibit the action of the cyclin-dependent kinases. And so there's supposed to be control systems here. And these can be activated by signals like P21 and those halt the cyclin-dependent kinase activity and cell progression. And they'll do that when they're working right. They will do that if there's surveillance indicates a problem, like a lot of DNA mutation or some other significant problem with the cell that it should not move forward. These are all proteins. They're all coded for by genes. If you have mutations in those genes, some of this stuff is not going to work right. I'm going to pause our recording for. So hopefully that was a not very long pause for you. All right, so we already established these are all proteins. They're involved in control of the cell cycle, and the genes that control these proteins can all be mutated. And so disorders of any of these can lead to the development of cancer. All right, so you don't have to memorize this graph for any reason. What I wanted to show you, okay, on the x-axis we have time, and on the y-axis we have concentration of these proteins. And so let's take a look at cyclin D and cyclin E. This is G phase, G1 phase of the cell. This is where cells spend most of their time. The cell's building up, it's making cyclin D. Once cyclin D reaches a certain point, then cyclin E kicks on. You start making a bunch of cyclin E. And the cell is not supposed to move forward into S phase, into copying the DNA, until these cyclins get to high enough levels. That's going to cause their cyclin-dependent kinases to open the gates and go right ahead, move forward into the next phase of the cell cycle. And so likewise, at the other places, the cyclin A has to increase before the cell can move from the S phase through G2. Cyclin B has to come up real high in order to progress through the next checkpoint. I'm not going to test you on all those individual cyclins. I just want you to get this idea. There's multiple of these control proteins happening, and any of them, the genes for any of them can get mutated, and the control systems for developing any of these can get mutated. And all of those things can contribute to developing a cancer. All right, so the checkpoint proteins, they're in place to control progression. Some of the ones that you'll hear about, RB, it stands for retinoblastoma because it was discovered in retinoblastoma, but RB is in all the cells, and it's one of the gatekeepers that won't let the cell advance from G1 into S phase. It won't let the cell start copying the DNA until it gets the correct signal from a cyclin-dependent kinase. P53, P21, these are proteins that are guardians of the cell. They help manage a lot of the processes of the cell. They're all considered tumor suppressor genes or tumor suppressor proteins because they slow things down in one way or another. And so we'll see them mutated in cancer. This is not a coincidence. It's because mutations occurring in the control systems cause the cell to go out of control. So the way it's written here, it sounds like, oh my gosh, what are the chances of this mutation being found in all these different cancers? The chances are high, because if you mutate any of these, you're going to get overgrowth of cells. These are the pages to find this information. Some terminology, I'm not going to read them all to you. You can read. There's terminology here. The one I wanted to point out, carcinoma in situ, you'll still hear this. It's in Latin. It means there's carcinoma, there's cells that are behaving badly, abnormal cells, but they're still contained. They have not reached their little area. In contrast, malignant, again from Latin, mal, meaning bad, the bunch of cells have poorly defined margins, meaning that it's not this nice little round pocket. It's now some of those cells are leaking out, pushing out. More terminology. Many cancers originate from the epithelial tissues. So usually we think of epithelial tissues as the skin, but they're actually everywhere, lining all of the ducts of all of the glands. Those are all cells of epithelial origin. So carcinoma is the term for cells that come from epithelial origin. Sarcoma means cells from mesenchymal tissue, connective tissues, cartilage, well, actually muscles as well. Blood cancers, melanoma is a specific kind of skin cancer. It arises in the melanocytes. And teratoma, you'll see this. This is germline cells coming from eggs or sperm or even zygotes. Okay, you've seen this terminology, the proto-oncogenes, oncogenes, and tumor suppressor genes. I'm not going to read it to you. You can read, you can always pause this recording and spend a little time working through this. What I wanted to show you related to this is two things. With the proto-oncogenes being converted into oncogenes, basically it's gaining function. That is, it's going to be overactive, and a single mutation can let that happen. In contrast, the mutations that lead to cancer related to the tumor suppressor genes, you need two mutations because you need it, both copies of that that protein's instructions, that gene needs to be mutated in order to not be making that protein properly anymore. And these are loss of function mutations. So gain of function mutations for the proto-oncogenes becoming oncogenes, and loss of function mutations for the tumor suppressor genes. And again, you may be thinking, what are the chances? Well, think about it this way. Mutations could occur that cause the tumor suppressor genes to work even better, slow down the cell cycle even more. You know what? That's never going to result in a cancer because it's slowing down the cell cycle. And likewise over here, the proto-oncogenes, you can mutate them so that they don't work. Again, that's never going to lead to a cancer. It's this particular combination of kinds of mutations that leads to the overgrowth of the cells. Some of the hallmarks, lots of signaling, meaning go forward. We talked about the RAS signal. That's one of the things that's really common to be mutated in cancers. There's growth suppressors, P53 and P protein RB, that the gatekeepers that are supposed to keep the cell from cycling through, and the cell evades it, somehow gets around those control mechanisms. And then remember, we said, so cancers kind of, in order to get cancers, genes have to mutate. And so you'll see mutated, you'll see basically loss of being able to control mutation. In other words, one of the proteins that usually helps with controlling typos and fixing typos, that protein is not functioning properly. So it's not a huge surprise that we're going to see what's called genomic instability. There's going to be mistake after mistake after mistake. And again, not a coincidence. Some more things that cancer cells do. They resist apoptosis. So the cytotoxic T cells, you'll remember from last week, they should be signaling to these tumorous cells, like, hey, you're not functioning properly, go kill yourself. And the cancer cells, they don't pay attention to that signal. That's what makes them cancer cells. If they paid attention to that signal, then this would be controlled and we would never get a tumor to grow. And then this other trick, angiogenesis promotion. Cells depend on the circulatory system to bring them supplies and get rid of their waste. Well, if you just have a pile of cells with no nourishment, that pile of cells is going to die. And so the successful tumor cells are the ones that somehow can trigger the body, to trick the body into making blood vessels to feed that tumor. Invasion and metastasis, that's moving, the cells moving outside of the area. Evasion of immune destruction. This is important. So one of the things that we found that some mutations in cancer cells, they actually inhibit the T cells from making copies of themselves. So the cancer cell itself is like, first of all, I'm not going to pay attention to that signal that you're telling me to go kill myself. But two, I'm not going to let you, the T cell, make copies of yourself. And so now one of the treatments is so anti-neoplastic, so anti-new growth, anti-cancer drugs include the immune-based therapies that are basically they make the cancer stop handicapping the immune system, and ultimately those medications let the patient's own immune system take care of the cancer. No idea why I left this one in. Oh, the cells deep inside here. It's I don't know if it's worth it. They become more aggressive, more likely to be invasive. And again, the other way of looking at that is those cells that are in the middle of the tumor and are not aggressive, they die. And so we don't hear about them. All right, here's an interesting thing. Remember how last week we talked about how the lymphocyte side of things, of the immune system, the adaptive immune system, how that coordinates with the inflammatory process. So here's evidence of this. So the immune system, the immune cells have been kicked on, and they start stimulating the inflammatory cells. And so we start getting symptoms as if the person had an infection. There's inflammation and an increase in these cytokine cell signals, leading to fever, malaise, lack of appetite, clotting. The complement cascade is triggered, but so is the clotting cascade. And so there's hypercoagulability. There's a risk of making clots. Patients are exhausted, no appetite, they're losing weight. Here's some tumor cell markers. They're indications that there might be some cancerous activity. For reasons that we don't fully understand, there are certain cancers that start secreting hormone that are not related to the organ where they originated. For example, SIADH, inappropriate antidiuretic hormone. Antidiuretic hormone is produced in the head, but it can also be produced by some lung cancers. And so when you see flags like that, and we know from empirical experience, not because there's any way to predict that lung cancer would ever make that hormone, but we know if you see somebody with SIADH and there's nothing wrong up here, look for cancer in the lungs. Okay, so tumor lysis syndrome, this refers to what happens when you initiate treatment for cancer. So there's a bunch of cells in the body that you're about to kill. Think about some of the things that happen when patients have a bunch of cells die for other reasons, like a crush injury or burn. Well, some of the things you have to look out for in those cases is hyperkalemia. Remember, most of the potassium in the body is squirreled away inside the cells. And if you smash a bunch of cells open all at once, sorry about clapping in your ear, what was I saying? So the potassium is suddenly released into the bloodstream. So we have hyperkalemia, same deal with phosphatemia. Now this one's a little bit funny. Having the high phosphate causes, it binds to the calcium that was in the bloodstream. So we see the sudden tanking of calcium levels. And then again, hyperuricemia, because that's being released from the cells. These can precipitate acute renal failure. And so before you start treating somebody's cancer, you do a risk assessment and figure out like, okay, how fast are we going to do this? And what do we need to do to safeguard this person's kidneys? I already mentioned this, the germline mutations. These are a minority of cancers. It does happen. People are born with a head start on a cancer, but most cancers are not of this kind. There are so many things that can lead to mutations and the development of cancer. Usually this is long laundry list. One of the things that I want to point out, though, is that the cancers that develop as a result of some of these insults are not always obvious. So for example, smoking, yeah, lung cancer, huge surprise, pharynx, but also kidney, ureter, bladder cancers are associated with smoking. Same with alcohol intake. Yeah, you could maybe guess liver. We know that there are other problems with the liver associated with alcohol intake. But yeah, also the pharynx, can be impacted, and other cancers can develop as a result of excessive alcohol intake. And like that, all of these, they have the obvious effects, but then there are some cancers that maybe you wouldn't predict. Here is just a listing of some of the hereditary cancer syndromes. The one that I want to draw your attention to, okay, so this TP53, we're talking about that P53 protein that is such an important tumor suppressor. And so when it's mutated, there's this head start. You've heard a lot about the BRCA1 and BRCA2, or BRCA1 and BRCA2. These are, they work like tumor suppressor. The proteins that are made from those genes work like tumor suppressors. And if somebody has a mutation in one of those, that tumor suppressor is not working. So again, it's no guarantee that a cancer will develop, but it's a head start on developing a cancer. Here's the regular list. And then, as we discovered a couple weeks ago, some pancreatic cancers we find are also associated with the BRCA1 and BRCA2 gene mutations. All right, then there are some chromosomal changes. And what that means is we're talking about something bigger than just a few letters in the DNA being wrong. We're talking about an entire piece of a chromosome coming off and attaching itself to a different chromosome. And I know that that sounds insane, but it is something that happens, and people, survive it because all the genetic information is there. It's just in a different place than you would predict. Let's see, what did I want to tell you about this? The Philadelphia chromosome. So it's a funny name, the Philadelphia chromosome. It is so called because the two scientists who were working on it were in institutions that are both in the city of Philadelphia. And so, again, nothing really related to Philadelphia other than where it was discovered. It's a translocation between two parts of two different chromosomes. So chromosome 9 and chromosome 22, there's this one spot in both of them where they're likely to break, and then they can switch parts. And what that does is it creates this protein that's a kind of a combination of these two genes. And that kind of funny hybrid protein, it's a tyrosine kinase. Which is a receptor molecule. It's on the outside of the cell, and tyrosine kinases are the receptor molecules that work with cell growth pathways. They're stimulated by growth factors. Well, this abnormal one that gets made from this hybrid of these genes, it's on all the time, even in the absence of the growth factor. You don't have to have the signal. This receptor is like, oh yeah, go ahead, copy yourself, make copies of the cell. And so no surprise, it develops into a cancer. There are viruses that can mess with our genetic code in a way that can develop cancers. There's no guarantee that the patients who have these viruses are going to develop cancers, but they're well known to be related to the development of cancer. So Epstein-Barr virus can lead to a kind of B-cell lymphoma. Hep B and Hep C, both of those, I guess this isn't hugely surprising, it's a liver cancer. HPV, several strains, for those of you who love details, strain 16 and 18, if memory serves, they can lead to the development of cancers. This is what's being checked for when you take a scraping of cervical cells and check every year for younger women, the the Pap smear. What you're looking for is dysplasia in those cells. And largely the dysplasia that can occur is largely, you can trace it back to the presence of the HPV virus, the human papilloma virus. Note, we now have vaccinations against Hep B and against HPV. And so it doesn't seem well, it seems like magic to me. I'm older. HPV used to just kill people. It was an inconvenience because you might get genital warts, but this could develop into a cancer that can kill people. And now the whole infection can be prevented by getting the vaccination early enough before the person becomes sexually active and exposed to HPV. Same with Hep B. All right, so genotyping, why we would do that, it's trying to figure out what exactly is going wrong here and what medications do we have that will counter that problem. Because if you can identify what exactly is going wrong, then that medication can be super targeted. You don't have to resort to those older chemotherapy agents that have so many effects on so many cells around the body. So here are a few medications mentioned. Remember I said that fused gene product, this is from the Philadelphia chromosome. So it has that tyrosine kinase that's funky and it's just always telling the cell to go, go, go. Well, there are medications, I don't want to say it wrong, imatinib, that target that particular receptor and tells it to like stop sending that signal. And that's not going to affect anything else. It's just going to target those receptors. It turns out this medication, the same medication that inhibits that particular receptor, also impacts this other problem that can lead to cancers. And so some of these medications can be used to treat other cancers. So the HER2 gene, I wrote here, human epidermal growth factor, because I can never remember that. What am I trying to sell? So that these are active in cancers like breast cancer. So even though the person doesn't have that Philadelphia chromosome problem, it turns out this medication will help in some of these other cancers. And then some other targeted therapies. Pediatric considerations. Solid tumors are less common in kids. It's many of the cancers that develop in kids, the most common cancers that develop in kids are associated with the bloodstream, are the leukemias. Here are some other, some solid tumors, but mostly what we deal with pediatric cancers are leukemias. This listing, it's supposed to be a mnemonic. It's awful. What it is a really comprehensive list of signs and symptoms of cancers in children. So don't worry about trying to memorize this as a mnemonic. Just you can use it as if you start seeing this constellation of symptoms in a kid, it may be indicative that the child has developed a cancer. And this is our last slide for the second half. This is also related to age and cancers, but this time we're talking about older adults. This is a super confusing graph, so let's walk through it. Down across the bottom, we have time. So as we go across the screen, we're getting older and older. There's nothing on the y-axis really. What you're seeing here is basically here are the mutations that happen, and we're accumulating them over the years of our lives. So oncogene activation, tumor suppressor gene, loss of function, apoptosis gene, loss of the ability to react to the signal that says turn yourself off and kill yourself, to cells. We're gaining more and more and more of those mutations over time. Okay, at the same, so this makes it more likely that cells will start copying themselves inappropriately. Then up here, what we're looking at is our own body's ability to control that kind of growth through things like activity of our lymphocytes. So our ability to fix things, to fight off not infection, but growth of these inappropriately growing cells, that decreases. Host resistance decreases over time also. And this is the explanation. So it's this combination of things. One, we've accumulated more mutations, and two, our mechanisms of controlling this inappropriate growth is decreasing. And so we're seeing more and more and more cancers the older the patient gets. Now, there's no obligation for the patient to treat every single one of these cancers, especially later in the life. Chemotherapy is hard on people. The cancers in older patients, they're slower growing. And so as the plan of care develops for these patients, we have to take into consideration some of those other factors. Yes, these older patients are more likely to develop the cancers, but then we have to start considering things like overall, how healthy are they? How are they going to do with cancer treatment? And so although you would think that you would be monitoring all the time for cancers, we actually kind of back off on some of the screening for cancers in our most elderly patients. And with that, we will end today's part 2 of chapter 7.